Oh my God, I'm so excited to be back at clinical after the pandemic. I haven't been in school in so long. Okay, 2 patients, I got that. Yeah, I can handle it. Okay, hold on. What did she say? Report. Oh yeah, I've taken report from these nurses plenty of times. Hold on. Give report? What? Hold on. Is she crazy? I can't give report. Nobody taught me that. It's not in my nursing school book. Oh my God. Whew, that was a long clinical. Okay, my 2 patients are good. They're still alive. Give report. I don't even have a pen. How am I supposed to give a report if I don't even have a pen? I don't even know where anything is. Oh my God, this was not in my textbook. What the hell am I going to do? I'm just going to go sit in the bathroom and cry. Okay, you know what? I quit. Nursing isn't for me. No more Lynn RN. No. No RNs, no letters behind my name. I don't give a crap. Bye. I'm out. Hey, it's your girl, Lindsay, aka Lynn RN, aka the Virgo Queen. So, today we're going to be doing a nursing segment where I'm going to be detailing how to give report. Yay! This can be an intimidating topic for a lot of nurses. So, this is going to be targeted more for student nurses or new grads going to the hospital. So, we've all been in this scenario before. Okay, so now I'm going to break it down for y'all real simple on how to give report. So when you're giving report, so the first thing to ensure that you're going to give the oncoming nurse a good report is that you receive a good report. Now, not every nurse is going to give you a good report. If you still have a nurse that is not willing to give you a good report, as a student nurse, you can always go to your clinical instructor and don't be afraid to do that. And just for next time, she won't put a student with that nurse necessarily if she has that option. For a new grad nurse, you'll just have to look up the information yourself in whatever computer system you use. It's not that hard to navigate. It's just going to cost you some extra time, which is hard when you're a new grad and you don't really know how to time manage yet, but it's not impossible. So that's the first foundation to give a good report, is to get a good report. So after you received a good report, you've asked all your questions, you've researched your patient to fill in all those gaps, you've been caring for that patient between 8 to 12 hours, and now you're ready finally to give a report to that oncoming nurse. Now, let's get into giving the report. Now, in school, like when you're calling a doctor, they teach you the SBAR method: situation, background, assessment, and recommendation. The way you give report to another nurse is pretty similar to that. So you're going to start off with like the patient demographics. I'll give an example of one of the patients that I had in the hospital. Of course, I'm going to leave out all identifying information. And we'll just do like how I would do a report on this patient. So Miss So-and-so in room 1, let's just say in room 1. So you're going to list off the name, what room they're in. Okay, so we make sure we're all on the same page with that. Okay, 48-year-old female. The demographics: no known drug allergies, great, full code. Those are all the things you're always going to start off the bat. And if you don't know one of those informations, that's a problem that you have to figure out before your shift is over. You don't want to come on and be like, well, I don't really know the code status of this patient. Nobody ever checked their allergies with the patient. No nurse is going to accept that. You're going to have the information out before the end of your shift. And if this is the patient you were taking on, that's information that you would have to have before I took over care on a patient. That's something that I need to know, unless they're like a new admit from the ED. Maybe they haven't checked the allergies yet because it was an emergency or something like that. And if there's no code status, you assume everybody's full code unless you're told otherwise in writing. Okay, so after we do that, okay, so cool. All right, so then if you're on the floor means you're on a med surg floor or a telemetry floor or a step down floor. So that's floor nurses. So specialty nursing is like ICU, ER, labor and delivery, OR. So floor nurses is like med surg and tele and step down. So I want to say, so this patient's MSP with monitor. So that means that she was admitted as a med surg patient and she's on the monitor. So we know that
I would also include here that the patient is normal sinus rhythm on the monitor when I talk about if the patient is on the monitor or not.
She came in with shortness of breath and back pain, chills, and a fever times a few days. Okay, so that's the situation. That's what brought her to the hospital. That's what her complaints were. Okay, and then she was admitted with pneumonia. Okay, that's why she was admitted. That's her medical diagnosis. The situation is what the patient is verbally telling you. That's their chief complaint. And the reason they were admitted is the actual medical diagnosis. Okay, cool. So now we're going to go down to the actual assessment now, because we just did the background. The background. Now for this particular patient that I'm giving an example on, she actually did not have any past medical history whatsoever. So if you did have a patient, which is very rare in the hospital that she didn't have any past medical history, but if you did have a patient that had an extensive or whatever past medical history, so after I said she came in with shortness of breath and she was admitted with pneumonia, then I would have said she has a past medical history of COPD, asthma, hyperlipidemia, past surgical history of a cabbage, Appy, Coley, you start getting into your alphabet soup. So a lot of times you try to start from the head down when going over your assessment, and even when doing assessment, the nursing school they teach you head to toe assessment. But oftentimes in the hospital, I'm working the night shift. I'm trying to go home. The day shift people, when 7 o'clock rolls around, they want to go home. So they don't necessarily want to give a lengthy report. So we're really focused on the system that that patient is admitted for, and any other system that there's a problem. So this lady, we already talked about it. She was admitted for pneumonia. So I'm going to focus on her respiratory system when I give a report. Okay. So I'll say she's alert and oriented ×3. She has coarse and fine crackles throughout all lung fields, and she's on 4 liters nasal cannula. Patient complains of shortness of breath or an exertion, and she has a productive cough, and she has worsening shortness of breath with coughing. Okay, so that's the main thing I'm going to focus on with this patient. If I'm giving a quick report under the assessment, that might be mostly what I say. And some things that you always have to include in your assessment, no matter what they're here for. So what else I would include? I would say her last bowel movement was blank. Her skin is intact. This patient was self, which means she can get up in and out of bed and go to the bathroom by herself. If she couldn't, I would say this patient is a standby assist. She's an assist ×1 to the bathroom, because that's the things that the nurse needs to know before they take over the care. Like, other thing that you have to know, and you have to pass on to the next shift, is what line they have. So this lady, she had a 20 gauge in the right AC, put in whatever date it was put in. Every hospital is different. At my hospital, we could keep an IV in for 3 days before we had to change it. So the nurse really wants to know that, because if you're giving me an IV and I have 4 hours to change it, that's really crappy, and you really should have changed it before your shift ended. So don't be that nurse. Change that IV. So the nurses, that's one of the key things they're going to ask you. When was the line put in? And they're going to give you this look like this. And guess what? Oh, it was put in 4 days ago. Guess you're going to be changing that line before they leave. Especially if you're a young new nurse on the unit, you're going to be changing it. So, and she has normal saline running at 100 mLs an hour. Then we'll get into the diagnostics. This is the next part of the report, okay? So what testing, what have they done for this lady? So we had a chest x-ray which revealed multifocal pneumonia. Okay, cool. So we have admitting diagnosis of pneumonia. So it could be assumed that the chest x-ray showed pneumonia, but we know the pneumonia is multifocal, which is probably why we have the coarse and fine crackles throughout her lungs, and it's not just in one lobe. Okay, that makes sense. And she's also positive for the flu type A. Okay, so she's positive for the flu and she has pneumonia, so she has like a double whammy. And we also know that when patients are positive for the flu in the hospital, they're on droplet precautions. So that's not something that was mentioned earlier in the report. Maybe it would have been mentioned later in the report. But if not, once I got to that point and the nurse hadn't mentioned she was on any precautions, I would wait till she finished, and then I would ask her, is she on droplet precautions, and if she said no, then I would make sure we set that up before the other nurse left, because it's just a standard operating procedure in any hospital for flu. You have to be on droplet precautions. Okay. So we taken a blood culture that's pending, and we got a sputum sample that was negative. So after that, I would go into if this patient has any consults, like if pulmonology was consulted for her or whoever was consulted for her, anything crazy with the labs, if her urine tox was positive for cocaine, if her last glucose was 500, something crazy, I would also include that. But all this particular lady's labs was all good. She didn't have any consults or anything like that. Anything crazy that happened in my shift, I would add on here so it can like paint the picture. So and then the very last thing that you say after all that is the plan. So the plan is we need to wean this lady off the oxygen before we send her home. That's just the plan. So we're trying to work on weaning her down from the 4 liters to room air. So that's just the plan for her. So that's basically how you give a report. Oftentimes, in regards to the vital signs, at least at my hospital, the report sheet that we get has the latest vital signs on there. I usually don't go too much into the vital signs unless it was something abnormal. Like for this lady, I maybe would go into the vital signs because she's on oxygen. So I would be like, well, she's satting 99% on 4 liters. Maybe we could wean her down. Versus like she's satting 94% and she's on 4 liters. So either way, both of those are important to mention in the report, because the oncoming nurse knows, like, okay, you know, is she running fevers, things like that. That's all important for the ongoing nurse to know. One thing I also did not mention was diet. So you always want to know the diet, especially if the patient's an NPO or something special like that. The oncoming nurse is really going to want to know that. Keep it short, sweet, factual, and to the point. Listen, the oncoming nurse does not care that Miss Jane Doe that Miss Jane Doe's daughter is an ex-heroin addict and she's stressing her mom out now because she keep on calling her, asking her for money. And listen, unless it's going to affect that patient, unless her daughter going to come up there and disrupt the hospital environment, the oncoming nurse doesn't care about that. She doesn't care. I just want to know, is the patient okay? How's she doing? Is she alive? Is she breathing? Okay, that's what the oncoming nurse cares about. So especially do yourself a favor, keep it short and sweet. And if they have any questions, let them ask you. Just give a concise report, factual, and anything you would want to know, tell them. But leave the drama out of it. So to break it down, number one thing, you have to receive a good report to give a good report. Okay, so keep that in your mind. So if you feel like you're not receiving a good report, ask those questions and look up the patient. 2, keep it concise. You don't need to know the patient's whole life story. The ongoing nurse don't need to know the patient's whole life story. Keep it concise but factual. If you follow those 2 things, your report will be gravy. Number 3, for the most part, follow the SBAR form of communication to give report. Okay, but you're starting off with demographics, and then you're going to situation. What brought the patient in? Why were they admitted? The medical diagnosis. What's their past medical history? That's the background. Then assessment, you're going through the assessment, what lines they have. Are they a self-patient? Are they walkie-talkie? You're going through all that. Also under assessment, you're going through any diagnostics, their vital signs, their labs, anything outstanding, things like that. And then recommendation, not necessarily your recommendation, but the plan for the patient overall. The report is not hard. Once you get the hang of it, it's easy, simple. It's going to be like snapping your fingers. Listen, don't freak out. Calm down. Chill out. You got this. Thank you for watching my video. If you want more videos like this, make sure you like and comment below. And as always, subscribe to my channel. I really appreciate it. Thanks, everybody. Bye.